Welcome everybody, and now we are going to our next speaker, Dr. Rory Page. Actually, Dr. Rory Page, he was my senior consultant about 15 years ago, and now I am very honored to present him and for the next lectures. Professor Rory Page is a consultant of anesthesia and the head of the department in the Cavan General Hospital in Ireland. And at the moment, he is a council member of the
نعم
College of
لا لا خلي
Statistics in
أنا أسمع
Ireland
المحاضرة المهم.
for Hospital Inspection Program. And his talk today about the anesthesia, age, and the brain. And is it good for us or for me? We don't know. We will see the answer of Professor Rory Page. Just before his lectures, I give very short notes about Kevin. Yeah, I know somebody maybe don't know what is Kevin exactly. It is in the north of Ireland to the south of the Northern Ireland. And it is about 116 kilometers from the largest city in Ireland, Dublin. This is the capital, of course. And this is about 2 hours drive Dublin to Cavan. And actually, Cavan is very nice town, and I have very lovely memories in the Cavan General Hospital with the hospital staff, with the nurses there, with the people living in the Cavan General Hospital. Actually, Cavan General Hospital has a very busy maternity unit. That's why very advanced anesthetic services to cover this maternity and obstetric very busy units. So you may ask why it is very busy units. We can see from this report, Ireland has the highest birth rate and the lowest death rate in the Europe. That's why we have most of the hospital dealing with the obstetrics usually is very busy because of this high birth rate. So this is very short about Cavan and Ireland, and we will come to our speaker, Dr. Rory Page. Welcome, Dr. Rory Page.
So where do I start? Well, first of all, I'm going to have to correct Professor Zaghul and tell him I'm not yet a professor, but still Dr. Rory Page. But I'm very happy and very pleased that you've introduced me in such a very kind manner. And you've told me something about Cavan I didn't even know, and about Ireland and maternity services that I had somewhat forgotten. But anyway, I have to give thanks to Dr. Saad Mahdi and the Academy organizers for the invitation to speak on this topic. So hopefully I'll try and speak as clearly and as slowly as possible so that everybody can understand my Irish accent. So it's also a very good. I'm very pleased and honoured to follow Professor El Ascalani's talk, which was very erudite and even I found illuminating and very interesting. It's a very important topic to mull over every so often. So to the topic at hand, anesthesia, age in the brain. I think it's a very important piece for anesthesiologists to think about, particularly those who provide any pediatric care and certainly care for their elderly patients. And of course, many childhood anesthetics involve minor superficial procedures, and they're quite often done in non-pediatric centers. And so it involves very many anesthesiologists. And hopefully in addressing this issue, I'm going to hope to conclude a relatively neutral position on anesthesia and any potential neurotoxic effects. The other important reason I thought this was a good topic to talk about is that this is one that comes up or could come up in written or oral examinations to test what we now call the professionalism of the candidate. and certainly in relation to patient and parent communication. And this actually follows very closely on Professor Ascalani's talk on consent. Hopefully you can see my screen, can you? Lou?
Yes, sound, and you may share your screen, please, Dr. Page.
Can you see my screen?
Share your screen, yeah.
Oh, yes, please.
The
Oh,
slide.
sorry, beg your pardon. Here we go. So,
Oh, okay, excellent.
all right, okay. I'm going to go back a long time ago, even before I knew Dr. Zaghloul. And I think maybe some of you can think that have similar recollections or similar experiences. But certainly my first weeks in anesthesia could end up quite hazy. And I can remember coming home and, or in fact, I can't remember coming home. I'd come home and sit in the chair. I've been told that I'd nod off or sleep in the chair, or I'd go asleep during a phone call. And I certainly hold that this is related to the effect of exhaust gases after a long day's session over semi-open systems, doing ENT cases or quick urology cases. And so once I finish this lecture, perhaps I also have to watch my brain as I get a little bit older after all this exposure. So I'm going to start in 2015 and with this consensus statement. So in October of 2015, a lot of the North American societies and were enjoined by the World Federation of Societies of Anesthesiology to publish this advisory public notice. And the word public is important because it's available to it was made available to parents and guardians alike. It alludes to the possible effects of anesthesia on young children and by inference the developing brain. And it is directed at healthcare professionals and parents to the current state of science research. And it reinforced, it does reinforce the positive need and in general the acceptability of anesthesia for important surgical events in a child's life. But just as the good professor was saying, it does encourage open preoperative discussion on the risks and benefits around anesthesia and especially with the new scientific data available. And the other important piece of this document is that in the parents' reading section, it uses the term harm. And this lays open a very thorny issue and a very emotive issue for parents and guardians of children. This website, or this advisory notice also gives reference to a very worthwhile website called smarttots.org and is well worth looking at, recommended. And this is updated every so often, both for professionals and for parents. So very briefly, we believe anesthesia has always been taught as a balancing act between a favorable and least physiological interference while promoting its benefits. And we believe that the target organ or the target system in anesthesia is the brain and CNS. This has been certainly has been quite difficult to study, but nonetheless, newer methods and innovations have allowed clinical science to peer into the working brain, even the working brain during anesthesia and surgery. The virtues of anesthesia that are promoted are analgesia, amnesia, and they include certainly lately its antineoplastic effects. However, we can't ignore the physiological derangements that often need acute management, and we are kept constantly aware of its impacts on the respiratory and cardiovascular and even renal systems. And we've even come lately to understand that it has effects on the immune and the neurological system. Anesthesia, as we know, works on that target organ, probably through a multiplicity of actions, and probably through a multiplicity of receptors, namely the opiate, benzodiazepine, barbiturate, cannabinoid, and NMDA systems. But the final common effect that we want is induced coma or sedation. But that should never be confused with sleep, because it does not contain the REM or the non-REM sleep patterns that we commonly associate with normal sleep, and it also does not preserve the normal circadian rhythm. So for the next little while, I just want to talk about the evidence of any neurotoxic effects of the anesthetic agents that we use in common day-to-day practice. And I'll try and explain these with the associated biochemistry, the animal models, and then try and allude to the clinical translation of a lot of these pieces of evidence. So while we're doing that, we must always remember that clinical issues such as behavior are very hard to attribute to anesthesia alone, particularly against the background of surgery, surgical type of surgery, the duration of surgery, and of course, systemic inflammation, which has its own effects. This article on screen is a review article way back in 2006 by two very well-known or competent researchers called Mervicic and Levi, and they have used anesthesia as a means to understand the principles of inherited mitochondrial disease and how it affects metabolic pathways. And in the body of the text, they discuss the toxic neuronal effects of agents and how they are promoted by blocking key metabolic steps in the cell. And this happens regardless of the age of the cell or even the stage of its development. So within the discussion, they have proposed this very simple schema of the biochemistry pathways that occur within the mitochondria. And as we know, the mitochondria is the powerhouse of the cell. And the systems, as we know, are the oxidative phosphorylation system. I'm not going to go into great detail, but enough to say that there are 4 steps within the process. And each step is comprised of its own complex of enzymes and enzymatic processes. And as you can see, there's complex 1, 2, 3, and 4 in old Roman numerals. So it is known that anesthetic and sedative agents can inhibit more or less all or one of these complexes. So in mitochondrial disease, this is deleterious, where already one of these complexes is genetically muted or absent. But it is also to some degree undesirable, even when you have normal in the normal setting. In other words, where the complexes are not absent and appear to be working normally. So as the system is blocked at all levels, so we've just dealt with the oxidative phosphorylation system and its importance, and that there are 4 steps, and that consequently we believe that anesthesia works on these 4 steps, and consequently as these enzyme processes are blocked, we get precursors being built up within the mitochondria and eventually in the cell matrix. And this in turn becomes cytotoxic and induces a condition called apoptosis. Very briefly, apoptosis is a universal enzymatic mediated process for cell disposal without causing damage to surrounding tissues or other surrounding cells. It's present in all organs and almost universally present in multicellular organisms. And it is seen to help order the development of embryonic organs, and is present throughout adulthood, and subsequently is part of the aging process. The key characteristic of apoptosis is it's not a disease per se, unless it is accelerated or disorganized. And one of the most important markers of apoptosis, or one of the most important laboratory markers, is the measurement of an enzyme group called caspases. And these are important mediators of intracellular apoptosis. And of course, they can be used as biomarkers, as I said. Unfortunately, during anesthesia, what is seen in neuronal tissue appears to have an accelerated phenomenon related to apoptosis. Very briefly, and I'm not going to go into the details of this schema, but to say that there are two essential pathways to apoptosis. The top row indicates an extrinsic pathway, which is quite often related to lymphocyte induced apoptosis, and the bottom row is called the intrinsic pathway, which reflects oxidative stress. In both conditions, the final pathways relate to adapter protein induction within the cell matrix, which eventually which goes on to stimulate the caspase cascade system, which leads to cell shrinkage and DNA accretion, and the cell is eventually disposed of. So the issues for us this evening is, does this happen with anesthetic and the sedative agents alone, independent of the surgical stimulus, surgery, surgical type, and inflammation? And what is the clinical significance of this potential neurotoxicity, if any? And if there is felt to be any potential clinical significance, is there a mitigation strategy? In other words, can we somehow modify this, or reduce it, or eliminate it? So in the next little bit of the talk, we'll review some of the evidence, and it'll touch on some of the animal models and clinical translations that have been looked at. And we're cognizant, of course, that all clinical models are fraught with the extraction of the clinical effects of anesthetic agents from surgery and other disease modifiers, as we've already alluded to. So this is the seminal article that probably kicked off a lot of the debate in recent years, and it actually goes back to this journal, the Journal of Neurosciences, in 2003. And Todorovic is a well-known researcher in this area, and she found that she examined the rat model exposed to benzodiazepine, namely midazolam, isoflurane, and nitrous oxide, and examined their rats with a complex behavioral measurements, and at post-mortem they looked at brain histology, and they concluded that there were behavioral changes in their study group of animals, and that associated with this behavioral change, there was marked neurodegeneration throughout the rat brain studied. So we'll fast forward 10 years later. In 2013, a very similar study was taken on by by this group, Carla Ueda, and she looked at a mouse model, and they were trying to show, and they did, that alcohol and anesthetic drugs exert a very similar behavioral and histological changes in mouse brain. And these were especially accentuated in the presence of caffeine, which is nowadays a very common food and drinks additive that, and particularly that children and adults will quite often use. One of the noteworthy observations from this study was that the mice appeared hyperactive as occurs in ADHD in the human model. So from this study, I have taken the slide, and it demonstrates, I think, very well the histological results that they have commented on. And this has been very much an observational effort. The brain tissues were stained with silver staining for apoptotic areas, and the staining density can be measured either visually or with a software program, much as radiologists do with CT scans. The picture here shows the clear architecture in the top left control group. Some subcortical densities associated with apoptosis appear in the caffeine alone group, and both cortical and subcortical with diazepam and isoflurane. However, on the right-hand column of histological slides, these drugs have been administered, co-administered with caffeine, and the conclusion was that caffeine certainly seemed to synergize the effects of apoptosis of the benzodiazepines and isoflurane. Some people, or there was some suggestion that this may even have been caffeine affecting drug clearance of diazepam and isoflurane and allowing them to have their apoptotic effect. More animal studies. So in 2012 and separately in 2014, both in anesthesiology, two separate models, two similar models were looked at. These were macaque fetal model studies, where macaque mothers were given either in the 2012 study a ketamine infusion over 5 hours. And in the 2014 Creeley study, they were given the mothers were given inhaled isoflurane for up to 5 hours. The slide indicates, again, I think you can see these dark dots occurring in the 2012 study, which indicate apoptotic areas, and this is again stained with a silver staining. And this is occurring both cortically and subcortically and throughout the brain, the brain tissue. So they concluded that this that fetal apoptosis was promoted by ketamine and isoflurane, and this remains a signal for toxicity of these agents. So we will go and look at, is there any clinical translation of these purported apoptotic events? And DiMaggio in 2011 reported in Anesthesia and Analgesia that from a study comparing siblings, and these were who underwent general anesthesia and surgery versus those siblings in a family who did not, and they actually enrolled quite a number of children. But the obvious limitations of this study was that the controls may not have been quite matched for age and the type of surgery. It was just that they were siblings and that they had surgery. But this and as we know, surgery carries in its own right a marker and an inflammatory for general inflammation. So what they did actually show from this study was that at least when they compared um, other markers for potential neurobehavioral disorders in children, that, for instance, complicated birth had carried a 1.5 chance of neurobehavioral disorders over the normal background of an associated effect. And similar, just being a man or a male child made you that little bit different. However, the important characteristic here that they were able to determine was that any child who had undergone anesthesia with any of the surgeries mentioned 3 or more times before the age of 3, this was associated with a very stronger and observable developmental and behavioral accumulation of developmental and behavioral issues. The question arising from this paper is this nature? In other words, is it a physical effect or is it nurture? Is it a functional effect? Is it just a factor of children being afraid and not being happy with their lot? So I found this article, which was quite interesting. I will not attempt to pronounce the names because they're not very easy to pronounce, but it comes from the very prestigious and American Academy of Pediatrics journal, and it was reported in July of 2015. And this is a very interesting and simple, elegant study, although it required MRI. And what they did was they looked at a very small portion of IQ testing, which has to do with language comprehension, and applied this to children who had undergone anesthesia and surgery. And they looked at MRIs, brain MRIs, after their anesthesia and surgery event. What they very elegantly showed was a negative correlation between the actual grey matter volume, particularly in the posterior brain regions, and this portion of language comprehension. And this tends to suggest that this is not just a functional effect, but there is a physical component to what is being observed. In other words, their brains have got a little bit smaller. So we need some good news. Saul, in this editorial of 2016 in Anesthesiology, agrees that there is a potential for neuronal and glial cell apoptosis in the brain, particularly in the developing brain, but that animal models also suggest recovery of cell numbers over a much longer period after isoflurane exposure specifically. And he also suggests that this may be occurring in the adult brain in a similar fashion. So hopefully that this loss of volume that we've seen in the previous slide in pediatrics may be a temporary event, but that hasn't been tested. So Dr. Todorovic once again entered the ongoing debate, and she wrote an editorial for Anesthesiology in 2018. And she is still insistent on the observable CNS tissue effects and the possible related behavioral changes associated with these apoptotic events. She warns that the United States FDA still requires open discussion of the risks and benefits with parents, caregivers, and even pregnant women around the use of these drugs. However, the paper does not advise as to how a conversation should flow. In other words, how you approach this subject, and what emphasis do you place on the risks. So, while these editorials were deliberating over the issues and the potential hypothesis and theoretical events, an international multicenter trial was already starting to conclude with more precision. And this was a study which looked at the effect on infants of general anesthesia versus awake regional anesthesia for surgery. Generally speaking, superficial surgery such as hernia repairs, orchidopexies, etc. It was conducted in North America, UK, Australia, New Zealand, Italy, to name some of the countries. And they managed to enroll 722 randomly assigned infants for surgery that was of less than 1 hour's duration. The children were then followed up with quite detailed psychometric testing, which I'm not going to go into here. And they were followed up for a period of up to 2 years, or to the age of 5. And interestingly, they concluded that there was no perceptible difference between the two groups. And I suppose this is reassuring for the anesthesia community. But it still does not negate the basic science research, and it doesn't quite counter some of the professional bodies' statements that were already in the public domain, namely using the word harm. The study finally has asked for a more balanced epidemiological study, and because of the types of surgery, there was a high preponderance of male infants within the study, and they would like more inclusion of female children in future studies. So finally, in these islands, the professional bodies joined last year, and they created this statement. The bodies in this instance were the Association of Anaesthetists of Great Britain and Ireland, the Association of Paediatric Anaesthetists of Great Britain and Ireland, the Royal College of Anaesthetists, and the College of Anaesthetists of Ireland. Or should I say now the College of Anaesthesiologists of Ireland. Again, it doesn't dispute the significant studies and their implications. It assures parents and the general public of the necessity of anesthesia when it is clinically indicated, and that the epidemiology, they feel, does not show clinical translation for short single surgeries under general anesthesia. And this seems to be in keeping with the epidemiology. It also, interestingly, unlike the earlier public statement by the North American societies, it does not regard discussion of the neurobehavioral issues as mandatory at every consultation. But it seems to leave this open to suggest that it may sometimes be appropriate to discuss these. So overall, this has been a somewhat challenging but reassuring piece for providers of pediatric care, if not for the children's parents. But I suspect the role of media headlines will play an important impact in the future, and particularly once COVID is no longer the medical topic of the day. And our ability to present this complex issue to parents and even to colleagues in other specialties may become very important. And one of the practice areas to watch is perhaps in obstetrics, given the very small risk, if any, to the neonatal brain general anesthesia section. Anyhow, the issues have really centered around the developing brain, but I'd like to ask a question about the shrinking or even degenerating brain. Is there a risk? Will there be a risk for me? An important question when we are operating on more elderly people, and our elderly populations are increasing in some of our countries. A seminal article from 1955 in the Lancet by Bedford et al. Is still quoted by colleagues in psychogeriatrics, neurology, and general medicine, and it's proposed, and this article proposed an association between decline in everyday living and anesthesia and surgery. And of course, this did not look at the difference, or did not separate out anesthesia and surgery from many of the physiological disturbances that do occur. So I'm going to, without any further ado, have a look at some of the evidence of the impact of anesthesia on the elderly brain. Dong et al. Looked at apoptosis once again in human cell lines, and they also looked at beta amyloid production, and when these human cell lines were exposed to a well-known anesthetic agent, sevoflurane. Beta amyloid, as we know, is a protein that is associated with Alzheimer's disease and is quite often found in its pathology of CNS neurofibrillary tangles. And the message from this article is that, yes, there seems to be a positive association. So what we're seeing here on this slide, on the left-hand side, are the electrophoretic bands showing denser caspase in relation to exposure once these cell lines have been exposed to sevoflurane. And there is also denser beta amyloid electrophoretic lines. The right-hand part of the slide just is a means of giving some sort of mathematical expression to the cumulative expression of these densities. But in either case, it does show an increase in both markers. So Dong et al. Concluded that patients with vulnerable brains may be at risk, particularly in long-term or cumulative anesthetic exposure. Now, these were in human cell lines and not not by any means in live human subjects. A very similar study took human cell lines as a study model, and they exposed these to isoflurane and also measured apoptosis and beta amyloid production within the cell lines. And once again, these are the electrophoretic patterns that had been produced, and they concluded that, like Dong did in sevoflurane, that capsase was being both capsase and beta amyloid were being promoted in these cell lines once exposed. So, to give an Irish flavour to the meeting, this is an interesting article produced by Dr. Sinead Savage, who is an Irish Sciences graduate and currently research lead in Manchester University in England. And in writing a review in Brain Sciences, she talked about the possible putative mechanisms for nitrous oxide neurotoxicity. Interestingly, many of these mechanisms we are aware of as anaesthetists already, particularly the block at the methionine synthetase with subsequent abnormal vitamin B12 metabolism. But she also referred to the fact that nitrous oxide has effects on calcium transporters and subsequently apoptosis marked by increased caspase activity, much as in the earlier articles. So does this translate clinically? Well, we are all very aware of perioperative cognitive dysfunction as a described entity. It appears much more significantly in the elderly population and has a number of contributory factors, such as, again, surgery, the type of surgery, the duration. Obviously, cardiac surgery has an increased risk because of bypass. Pre-existing disease has an impact, and of course, the direct effect of anesthetic agents. So Steinmetz et al. have shown that at least the depth of anesthesia, as measured by BIS monitoring, is associated with an increased risk of perioperative cognitive dysfunction, implicating therefore the anesthetic agent. So whether this dysfunction is associated with a long-lasting decline seems to be more a function of pre-existing cognitive dysfunction. So there is some, there appears to be reversibility. And certainly in anesthesia and surgical circles, most people would feel that perioperative cognitive dysfunction, as unpleasant as it is a short-lived and reversible phenomenon. However, as I said a little earlier, this contrasts with many of our physician colleagues certainly in the psychogeriatric community, who still adhere to the old Bedford study of 1955, when in an era of less well monitored anesthesia and perioperative medicine. So in Ireland, as late as August the 31st, we live in post-COVID times. Well, not quite post-COVID, but in the COVID lull. And we are seeing quite a few newspaper articles about patients who have survived. And this is one typical headline: almost 6 months later, I still feel the effects. And what this draws on is the negative impacts of ICU delirium and neuromyopathic problems faced by patients who've had undergone prolonged ventilation and prolonged periods of sedation. As early as 2006, Dr. Wes Eli in the United States noted the predictive value of ICU delirium on mortality in ICU, and he noted this, and subsequently in a recent article in Critical Care Journal, Dr. Eli and his co-workers went to great lengths to talk about how tailored sedation strategies were very important to reduce the effects of critical care delirium during COVID. And they have been very eager that we would adopt, as a community, a worldwide community, tailored patient strategies for sedation, and in the hope to reduce ICU delirium. I can recommend their website, icudelirium.org, and this is quite often updated for professionals as well as the public. But it gives some references and help if in designing some of these strategies. So, in conclusion, and I'm sure you'll be delighted after this long evening to arrive at this stage, neurotoxicity appears to be a real phenomenon, and many of our common agents do appear to be implicated in apoptosis and some degree of neurobehavioral disorder. It is pronounced in developing brains, and there are signals that similar issues arise in older brains. The clinical translation, however, is conflicted, and but the professional guidance is there to tell us that the epidemiological evidence suggests that it is safe to give anesthesia, at least to children, as long as it's not, as long as it's of short duration and not amplified by frequent multiple anesthetics. There is no such advisory for in the elderly population. The other important implication arising out of this is around occupational exposure for our obstetric patients, pediatrics and geriatrics, whether in theatre and ICU. So in conclusion, short single anesthesia is clinically safe. And we'd also be glad to hear that that there is some evidence that some of the newer sedative agents, such as the alpha-2 agonists, dexmedetomidine, may not carry the same neurotoxic effect, and they may at least attenuate it during balanced anesthesia. So at the very end, I'm not expecting everybody to shout out the answers, but I will give I'll give a little time on. I'll just go through these 6 questions, and I know it's sort of routine nowadays when people are doing their reading. They try to do their CME questions. So question 1 is: apoptosis is both inflammatory and stress induced, and the answer, of course, is yes. We know from the discussion that there are 2 pathways, both in intrinsic and extrinsic. Question 2, epidemiology indicates that anesthesia in infants is safe under 1 hour's duration. And yes is the answer, and that is the epidemiological evidence, and that comes straight out of the GAS trial from 2019 in the Lancet. Question 3, ketamine improves postoperative psychometric tests. No, there is no evidence for that. And in fact, ketamine has been implicated in apoptosis and to some degree, certainly in animal studies, neurobehavioral problems. Question 4, postoperative cognitive dysfunction is usually reversible. And the answer is yes. Again, it really depends on, it also depends on the patient's precognitive state. Question 5, ICU delirium can be mitigated by sedation strategies. I think the answer to this would be yes, given the research done by Dr. Eli's team. And the 6th question and final, anesthesia discussion with parents is too difficult and should be avoided.
No.
I think that's absolutely.
Yes, thank you so much, Dr.
Yes,
Page.
and so yes, I'm open to any questions or any discussion.
We have just a few questions. The first question is about the repeated exposure of infant for general anesthesia. Is it possible to avoid this effect on the developing brain? And if the patient needed repeated anesthesia for any reason, is the change of the anesthetic agent can avoid this problem?
Well, I'm going to relate it to the professional body's advice, their advisory statements, and to what I've read in the literature. And there is no evidence that any change in a particular strategy or a particular format of anesthesia, all anesthetic agents have been implicated in apoptosis and to some degree neurobehavioral measurements. The question is, do you believe that this is a long-term issue, or is it something that resolves with time, and particularly in children? The epidemiology isn't there. There is some suggestion from Saul's editorial that certainly whatever brain measurements, loss of brain volume or brain cells that occur, that there is some recruitment later on. Now, whether there is nothing to say that changing strategy it mitigates any of these effects.
Change between inhalational and total intravenous anesthesia?
Unfortunately, the evidence is also concludes that propofol is also implicated in brain apoptosis. So it probably comes down to the frequency, the closeness, the proximity of anesthesia events. But again, this is speculation, and a lot of it is still speculation.
Okay. There is another question also about the apoptosis, which can be induced by hypoxia or any other brain injury. in the presence of the anesthetic agent, is this apoptosis can be more
Right.
worse or it can be protective?
Uh, well, the, the the studies we've quoted um, tend not to produce hypoxia, but they do. This is one of the confoundings, that hypoxia does cause damage, and is this a synergetic effect, or does it attenuate somehow? There is, again, it's speculation, but some of the authors have speculated that anesthesia with surgery, and particularly if during hypotension, this may not be a good thing.
Okay, yeah. Just a small comment from myself about the cognitive dysfunctions. You mentioned that it may be irreversible, but actually it depends on the severity. If
Of
it is
course,
just simple delirium and can be detected early, so it can be reversible. If it is progressed to cognitive dysfunctions, it may be more difficult.
yeah,
But
yes,
if it is neglected and the more progressed to dementia, this will be irreversible. So
I
it is delirium, cognitive dysfunctions, and dementia.
I would agree with you, Yasser. I think they're in experience, severe cognitive dysfunction appears to have prolonged effects and
Yeah.
may not be reversible. But again, looking at the literature, particularly the literature reviews, uh, quite often what we're seeing in the severe postoperative cognitive decline and the persistent postoperative
Yeah.
cognitive dysfunction are people with precognitive or preoperative cognitive issues. Maybe not measurable, maybe not something we've taken into account at the time, but maybe it was there nonetheless.
Yeah, maybe the last point I have to point for it is just as you mentioned, the depth of anesthesia and sedation increase the postoperative cognitive dysfunction. That's
Yes,
why there's a lot of new recommendations about the monitoring of PIS, especially in
yes,
each patient at risk of postoperative cognitive dysfunctions or long surgery to keep it around 40 or more. If
yes.
it's less than 40 for a long time, high possibility or high incidence of postoperative decline in consciousness or delirium or cognitive dysfunction.
Absolutely, I would totally agree with that, and I think that bears out from the literature and
Okay.
from our people's experience.
Yeah. Any
You
comment,
please,
Dr. Assam?
yes, please. Thank you, Dr. Yasser. Dr. Page, I have one question. I am working and walking every day in neuro surgery.
Yes,
And we spend a long time nowadays because we have a fellowship of transnasal tumor resection. We
yes,
spend more than 10 hours, 12 hours, or even sometimes 18 hours in the theaters.
yes.
And I am using total intravenous anesthesia for these patients.
Mm.
First of all, is there a difference between using total intravenous anesthesia and inhalation anesthesia for this patient? My second question, is it is it a matter of anesthesia exposure frequencies, or is it a matter of timing for the exposure? What is the difference and what is the more dangerous? Because sometimes we are receiving children, for example, for esophageal dilatation,
Mm.
and they are coming
Frequently.
every week, and they are exposed, and other people or other children burn, for example, and we give them some of the anesthetic, even intravenous or inhalation. So is it a matter of exposure or is it a matter of the duration?
I would think it's my understanding from the literature is it's a matter of probably both. Duration seems to count. The epidemiological evidence is that cases less than an hour's duration, and that came from the gas trial, that they seem to they don't seem to show any increased propensity or increased chance of neurodevelopmental problems. The the professional bodies do countenance and they do talk about the frequency and the spacing between anesthesia, and that comes probably out of DiMaggio's article, which showed that the hazards ratio for the number of anesthetics that in children under 3, if they have 3 or 4 more anesthetics, they increase their hazards ratio 4 times. Now, does that mean not every child is going to get a problem? Maybe not. It probably also comes down to the, there may be other variables that we're not taking into account, but nonetheless, they're the epidemiological pieces that we do have. So it's probably, in my mind, it's probably a combination of both. The essential thing is it necessary? Is this necessary surgery? And given what you've talked about, esophageal dilation, I can only imagine that this is something the child has to have done. And but surgeons do have to take into account, is this absolutely necessary now?
TIVA and inhalation. Is there any difference?
TIVA, again, there doesn't seem, nobody's made that distinction. Either professionally have given advice to say TIVA is better than inhalational. Unfortunately, as I alluded to, there is evidence that propofol, because it works on GABA receptors, is also implicated in apoptosis. Is it less severe, more severe? The literature isn't there to say.
Needs investigations.
Yeah, absolutely. And for our young investigators, these will be the things that people will be looking at in future.
Thank you so much.
You're very welcome.
Okay. Any comment from any other body? Good, okay. Saad.
Just give me 1 second. I would like to thank everybody tonight, and it is very, very informative webinar, and I'm so delighted that we have those eminent speakers tonight. And I want to share with you on Sunday, if you join us, we have a very similar international specific webinar on Sunday. We have 3 eminent speakers. Professor Hani Zahabi is a chair and professor of anesthesia and intensive care in Ain Shams University. Dr. Mu'taz Abdurrahman is a consultant anesthetist in Royal Manchester, and Professor Muhammad Tahan is a professor of anesthesia, and the moderator of that session is Dr. Manal Gohari, professor of anesthesia in Cairo University. So all welcome to participate and share us on Sunday, 13th of September. By this, I would like to thank everybody participating tonight. Prof. Nabil Askalani, Dr. Rory Page from Cavan, Prof. Hassan Manna, and Dr. Yasser Zaglul, Dr. Adil Ibrahim, everybody on board, all attendees, and thank you very much for tonight. And I'm so pleased for that successful session.
Thank you so much.
Thank you very much. Thank you.
Thank you.
Thank you.